So this is the ultrasound-assisted thrombolytic therapy in high-risk pulmonary embolism. This is not a very common scenario, but we do get these patients time to time. Thrombolytic therapy for pulmonary embolism, is it a real or is it justified? There are lots of questions before we go ahead with this kind of therapy. And it appears logical to remove the offending cause of the massive thrombus and immediate improvement in the failing right heart. Thrombolytic therapy immensely successful in dissolving clot in MI, but the same has not been translated into the pulmonary artery thrombus. Why? We don't know the dose, how long it should be continued, which agent should be used. Is there any mortality, morbidity benefit at the cost of either bleeding or stroke? So these are the major concerns which we have. So catheter-directed therapy pulmonary has local delivery close to the thrombus. That's the logic, and it appears better than IV thrombolytic. Probably the dose is less. Other techniques are thrombus removal or thrombolysis. Which one is better? We have to still decide which patients we can use that. And ultrasound defragmentation of thrombin and fibrin has been useful. And this is the approach which has been recently come across. I came across an interesting case, and this is a 40-year-old man. He presented with dyspnea and chest pain on minimal exertion, like climbing upstairs in his villa, and severe chest pain or sweating was absent. Obese, gastric bypass done 6 years ago, no history of prolonged immobilization, long flight recently, family history of DVT in father. So he had some anterior wall T wave changes, came with chest pain with minimal ST elevation, no RVH, no LVH, cardiac markers, troponin raised, CKMB raised, NT-proNP raised, and echo showed normal EF. However, there was an enlarged RV. So this was the ECG showing some ST elevation. So if you was considered a non-STEMI, angiogram was normal. So we started thinking of other causes, and you can see that there is a massive saddle embolism sitting across both the pulmonary arteries, and right pulmonary artery was almost totally blocked, and the lower and middle zone perfusion was decreased. Right ventricle is enlarged. So we did an angiogram, which showed again similar findings, that right, middle, and lower zone finding was less. And when we did a pulmonary angiogram, left field was also partially occluded. So catheter-directed therapy, ultrasonic sound-supported thrombolysis was attempted. And what it did, so that's the way it is placed. Both pulmonary arteries were cannulated from the right femoral artery. And if you can see those tiny dots, these are the ultrasonic ports on this catheter. And there are multiple perfusion holes for the perfusion of thrombolytic therapy. So this is the pre, and you can see the post on the lower slide on the left. The pulmonary field is filling up, and same on the full, you can see when selective injection was given. So there has been an improvement in echo, which is the D-shaped LV, which is a hallmark of high right ventricular dilatation, which presses the LV, and that is was changed. And this was the pressure. If you look at it, pressure was more than 96, and which decreased to next day or continued thrombolysis with the bolus, followed by infusion for 24 hours, and PA pressure come to around less than 50, which was almost 100% reduction, which is drastic reduction in terms of this. And look at the CT also showed significant improvement. And the bottom left, you see the pulmonary arteries are clear, and the top, you can see the saddle embolus, but there was some residual thrombus in the right coronary artery. So after this, he was continued on oral anticoagulant. Vitamin K antagonists were chosen because he had a gastric bypass, so we were not aware with NOACs, without knowing what is the degree of anticoagulation. At least in vitamin K, we could see what is the warfarin can do the PT INR level. Clinical improvement was continued, and this is the general schema which has been described. There is an increased pulmonary vascular resistance, which increases the RV pressure and RV overload. Dilatation of RV compresses left ventricular by pushing the IV septum to the left. diastolic dysfunction, and decreased LV cardiac output at later stage because RP is compressing the LV, and eventually RV failure, and that's how the patient succumbs in this situation. So there are various thrombolytic therapies have been given. MOPED-3 trial used 100 milligram in 100 patients, and they showed significant positive result. TNK was used in 50 patients, where the bleeding was significant. However, there was a reduction in terms of PA pressures, and MOPED-3 tried to reduce the lower dose of alteplase, and it was very effective without any increase in the bleeding. TopCat trial in 2014 shows TNK low dose was effective, and Pethico trial with TNK is used in 1,000 patients. There was still significant bleeding and stroke, so it was plus minus trial. In 2014, European guidelines recommend alteplase 100 milligram is superior. At least it has got better effects if it is given within 48 hours. Streptokinase, urokinase should be avoided, or the first generation, what we used to call them. So recently, these guidelines, they have tried to European and American differentiated from massive, submassive, and low risk, and that's how it depends on the abnormal RV imaging or elevated troponins, or both. That is the massive and nothing in non-massive. They can be treated conventionally by anticoagulants or local or orally subsequently. But these two groups, in European, they subdivided middle group, intermediate, high risk, where the high risk, intermediate, or high risk, they are closer to the therapy where thrombolytics has got better role. So what justification for thrombolysis? Clot selective thrombolysis are useful in massive, high risk, submassive pulmonary embolism. Long-term mortality benefit is not proven in intermediate risk patients. Low risk patients have no benefit. Lower dose has shown lower stroke and bleeding and cost effective. Sorry, I have difficulty moving. So various systems have been developed, like the suction catheters. These are basically to remove the catheters from pulmonary system, and these catheters have different results. And recent, there is a FDA warning for the angiojet system, which is not a black warning that this should not be used because there's more complications. Flow retriever has been a very impressive device, which has shown significant reduction in RV-LV ratio, and it has got disadvantages, got a 20 French cannula. German group, this is interesting data which shows more than 40,000 patients, and they used in different subgroup of patients, and the summary of the results shows whether it is a subgroup hemodynamically stable, hemodynamically unstable, or the patient who had a CPR. So obviously CPR patients are worse patients. They have not much hope, but still they showed improvement. But other two groups, stable or hemodynamically stable, they also showed significant improvement with thrombolytic therapy and further improvement with the cath-directed therapy. So ultrasound-assisted thrombolytic therapy experience has been still limited. I would say about 800 patients in various studies, and they have used in high risk or high intermediate risk patients. What they did, it reduced pulmonary artery pressure significantly, less than 10 or 20 millimeters. It changed their RV-LV ratio, which improved significantly. To bring you some old memories, I had this case about 30 years ago. It was 92 when we had this case. And intrapulmonary thrombolytic therapy I used with the balloon dilatation in recurrent pulmonary edema, pulmonary hypertension. So this was published in Indian Journal of Chest Diseases in 94. This was a 52 years old man, had a recurrent pulmonary thromboembolism following fractured tibia and subsequent deep vein thrombosis. One episode of massive pulmonary embolism with hemodynamic compromise was managed successfully by balloon compression. And this was our own thought process. We used the balloon with throat compression, and then used thrombolysis with urokinase, which was continued for 2 days or 48 hours. And after that, his PA angiogram was done, PA pressure was monitored every day, and it showed a gradual progressive decrease from 90 plus to about 50. So this was, you can have advanced devices and you can use, when you don't have it, you have to think of your own and you have to make an alternative, and this was done. And now it has got much superior devices we have. There are still some unknown territories. Is there a time window of systemic or catheter-directed therapy? Is it from the onset of the system? Like in MI, its clear-cut indications are available, but in pulmonary embolism, onset of disease is not so clear. Is the dose of lytic varies from acute to subacute state of pulmonary embolism? Like our patient had their symptoms for 2 weeks, but for 2 days, he became so short of breath, he could not walk up to the car, his car park, and he felt dizzy. So that's why then he came to the hospital. A longer infusion with a higher dose, more effective, with a lower bleeding complications. So if it, instead of a large big dose, it gives an opportunity. Are clot selective and agents are truly selective? If so, why we have a stroke, higher stroke and bleeding complications? Because if it is working on the strokes. So there is some generalized thrombolytic state established, which needs to be still known.
Dr. Lochan, kindly conclude your slide. We are running very behind.
This is the last but one slide. Knockout PE trial. It is the largest prospective interventional pulmonary embolism study of nearly 500 patients, including intermediate and high risk. And it showed RV-LV ratio reduction by 20% with no intracranial hemorrhage. This was a drastic change, and it was done with the help of a ECOS, and it is to be effective in lowering therapy treatment in this particular subgroup. In conclusion, encouraging results have been shown with newer suction embolectomy devices, which only have minor limitations. Evidence-based ultrasonic facilitated catheter directed thrombolysis system ECOS is a sleeker. Additionally, has shown quicker improvement in RV function with low rate of adverse effects. Catheter-directed therapy has surpassed surgical embolectomy, systemic thrombolysis, and will be the preferred mode of treatment, both high and intermediate risk patients, with availability of more data or information. Thank you very much. Sorry for the delay.
Thank you. Thank you very much, Dr. Lochan. That was very, very good. I mean, again, it just puts out the same point. You have been doing these procedures. This is a very new device which is not available in India. I would not say very new, but maybe it's new to Dubai. I mean, it was being used in US and Europe earlier. But again, I would go back to what I said earlier. You have always been very intuitive and think out of the box. I mean, 30 years back, you could think of a balloon angioplasty and crushing the thrombus and lysing the patient. And today there is a big rationale of, macerating the clot and then giving intra-arterial lysis just to increase the surface area and decrease the lytic dose, and to suck out the clot as early as possible. So this is the way things are moving in terms of DVT and acute pulmonary embolism, especially the massive and submassive ones. And many a times when you have situations where surgery is contraindicated, where anticoagulation therapy or thrombolytic is contraindicated, these are the only therapies which work. And if they work so well there, why not to use them in high-risk patients preemptively and by choice? I think Sachin is there, and Sachin was there in one of the cases. Like for last 5-6 years, what we are doing is in patients who come with massive PE and absolute contraindications to thrombolytic therapy or heparin, like road traffic accidents, immediate post-op, we actually go in with a suction catheter and suck out the clot. And the suction catheters are not very advanced or sophisticated ones. We actually just take wide bore guiding catheters or sheaths and go over the wire and try to take out the clot. And that itself starts the antegrade flow. It improves the hemodynamics on the table and brings down the PA pressure and increases the saturation. And then we put in 2 pigtail catheters and give just lytic TPA at a dose of 2 to 4 milligram per hour, and that actually takes care of a lot of pulmonary thrombolysis without causing enough bleeding. And now we have a data of about 50 patients. Sachin was, and both Rauf Malik, both were a part of this study when we were here, and I think one of the papers was also presented in TCT or EuroPCR. So let me ask Dr. Sachin also to come on the panel, Dr. Rauf Malik and Tamkeen Khanna to come on panel, and we'll have the second talk by Dr. Abdul Rauf Malik on updates on NOAC in VTE.